today I'm on Gadigal land, and I recognise that those attending are also tuning in from Aboriginal lands across Australia today as well. So I pay my respects to elders past and present. So welcome to Women's Health New South Wales Learn at Lunch, Reproductive Coercion with Professor Tarzia, a leading expert in reproductive coercion and abuse and sexual violence. She is the co-lead of the Sexual and Family Violence So Safe research program at the University of Melbourne, and also the director of the Restore Centre of Research Excellence. As reproductive coercion is an emerging priority issue for women's health, we were very excited when Professor Tarzia agreed to deliver this session, and I'm really looking forward to learning from her. A quick mention for those in the women's health sector and working with the Women's Health Database, the code number for reproductive coercion is 174 on the database. So we predict the number of recorded presenting issues for reproductive coercion doesn't really truly represent the women's experiences. So hopefully we'll see an uptick in stats after you get a little bit more familiar with asking questions about and identifying reproductive coercion. Improving data collection in this area will allow us to identify patterns of behaviour and psychological aspects of control, isolation, intimidation, and other forms of violence. So I'm going to stop talking now, and I'm going to hand over.
Thanks, Courtney, and hi, everybody. It's nice to be here and have the opportunity to talk about this topic that I'm very passionate about and have been working in this space for a number of years. I am coming to you from the lands of the Wurundjeri people of the Kulin Nations, and I pay my respects to elders past and present. I've got some slides, so I'll share those. So I'll just begin with a little bit of, I guess, more theoretical stuff, because reproductive coercion and abuse is an emerging area, and I guess compared to domestic violence and sexual violence, there's a lot less known about it, and I think there's a bit of still a bit of lack of clarity out there in the community and even within health and specialist services, to be honest, about exactly what we mean when we use that term and what sorts of behaviours are included in that umbrella. And this is also by no means an issue that is agreed upon in academia either. Like, we're still kind of debating some of these topics, and not everybody agrees with the way I like to conceptualize it, and that's fine. But what I mean when I'm talking about reproductive coercion and abuse is basically deliberate behaviours that are deliberately intended to interfere with somebody's reproductive autonomy. And so we generally categorise it into two forms. There is pregnancy preventing RCA, that is around forced abortion, forcing somebody to use contraception when they don't want to, or forcing somebody to be sterilised against their will without their consent. And then pregnancy promoting, which obviously is the flip side, where somebody is being forced to get pregnant, forced to stay pregnant if they had an unplanned pregnancy or something like that, sabotaging their contraceptives. So we can see things like, putting holes in condoms or hiding birth control pills, those types of things. So those are generally the two sort of forms. And I think that's quite a useful way to categorise RCA, because I'll talk about this a little bit later, but the sorts of contexts that some of these two categories of behaviours happen in can be a little bit different. And so it's also important, I guess, for clinical practice and understanding somebody's safety or risk, understanding what type of RCA can also be relevant to that. Okay, so this is also just to clarify that there's a lot of debate, as I mentioned, about what sorts of things should be included under the label of RCA. I think there are there's this broad spectrum of things that I guess we could classify as reproductive injustices. And that can include RCA on one side, so that's sort of more of interpersonal control over someone's reproductive autonomy. But then there's also other things that happen outside of that context. So, for example, problematic stuff that might happen within the health system around contraception, and practitioners sort of not being okay with abortion and not being willing to kind of facilitate that. At the policy level, absolutely, we're seeing this right now in the United States, of course, with policies around abortion access and stuff like that. That is that has really negative repercussions for people, particularly for women, who are the ones mostly impacted by reproductive coercion, where we can see those sort of structural things interfering also with their reproductive autonomy. I'm going to focus on the interpersonal type of RCA because I see a lot of those other things as, I guess, being facilitators or the opposite of things that can prevent reproductive coercion. So obviously good policies and policies that are good around women's reproductive choice and abortion and all those things, those things are not going to be facilitating RCA. But when we see environments where there's a lot of restriction and stigma and problems like that around reproductive choice, perpetrators are able to then weaponize those things as mechanisms to control people's autonomy. So I think that the reproductive coercion that happens within the context of an abusive relationship or within a family where there's also abusive behaviours happening, that is quite a different thing to what's happening at the structural level, at the policy level. It's all connected, but they're different, and the ways that you would address things at each level is different. So I don't think it's useful to kind of lump it all together and say it's all reproductive coercion. Part of this comes from the term reproductive coercion, which I think makes people immediately think of the general sense of coercion, and anything that's like influencing or coercing or restricting someone's choice should be called reproductive coercion as well. But I think that's just a language issue that kind of creates a bit of confusion conceptually around what we're talking about. So yeah, all of that just to reiterate that I'm talking mainly around behaviours that are perpetrated primarily by male intimate partners or family members towards primarily women or other people assigned female at birth who may not necessarily identify as women. I'm just going to refer to women because it's easier than saying all the things, but I also do mean others who maybe don't identify that way. But those are the people who have capacity for pregnancy, whose autonomy is being eroded and being co-opted as a mechanism of control. So this diagram really just visually represents exactly what I've just said. And I know some of that text is quite small, but it's just a sort of visual representation of how I see reproductive coercion kind of fitting into a broader framework of violence against women. So it's sort of within the intersection of family violence, intimate partner violence, and sexual violence. And then the things like the structural stuff, government policies, community attitudes towards women's role in reproduction and motherhood and all of those types of things, patriarchal norms, gender inequality, all of that stuff, that kind of, they are all sort of facilitators. And then on the other side, the protective factors around access to contraception, societal attitudes that destigmatize abortion and support women's choice, sexual health education, all of those things, those are protective. So then a little bit more contextual information. I see intent as really critical to defining RCA and distinguishing it from other violent behaviours that might happen in a relationship. So the perfect example of this is stealthing. For those not familiar with that term, it's non-consensual removal of a condom during sex. Stealthing can be RCA if it's done with the intent of getting the woman pregnant. But stealthing also happens for a whole lot of other reasons that have absolutely nothing to do with reproduction. There's been some, not much research, but some suggesting that men do this because they just don't like condoms and they think that they're wishes should be prioritized. They do it because of some sort of power play. There's all of that horrible stuff that happens on the internet, in Reddit and places like that, where men kind of talk about wanting women to take their seed and horrible things like that. Anyone who's seen that Louis Theroux documentary has probably seen a little bit of what I mean by that, but those sorts of things. So it's important then, certainly in a research sense, when we're measuring these behaviours and looking at how common they are within the community, and then from there shaping policy and interventions and best practice guidelines, we need to be really clear about what we're measuring. And so I have spent quite a lot of time advocating that in measurement, we are clear about the intent of the behaviour, because one of them is sexual assault and one of them is reproductive coercion. And I don't think it's useful to put all of that data together. We need to be kind of looking at the nuances of these behaviours. There's a really important role, I think, for fear and control, or both, in understanding reproductive coercion. Pretty much every victim survivor that I've spoken to about their experiences has sort of mentioned some level of fear and control. It is a very intentional thing, and it has pretty severe impacts on health and well-being of victim survivors and their children. So this diagram comes from a paper I published 2 years ago-ish. This is based on interviews, in-depth interviews that we did with around 30, I think, victim survivors of reproductive coercion. And we asked them about why they thought the perpetrator was doing this. What did they think was the rationale behind it? Because a lot of people often say to me, well, women don't know why perpetrators do things. We shouldn't be asking them that or using that as a kind of criteria for defining RCA, because they don't know. That's not been my experience. My experience has been that often they do know, or they can take a really good guess, because the context of everything else that's happening in the relationship is telling them this. And so most of these women articulated very clearly to me that the behaviour was happening, for example, in a context of longer term relationship violence, of control, of a lack of bodily autonomy in their relationship, and not being able to have a say, for example, about when they were having sex, or all of those sorts of things. So I do think that often women can answer this if they're asked about why. So what we found was that there were kind of 4 categories, I suppose, that these perpetrator intentions or motivations fell into. And this was quite interesting, because I found that, so the first group there on the left, there was a group of women who felt that the motivation of the partner, I think they were all partners from memory who were perpetrating, they had an unplanned pregnancy in most of these cases, and the partner was saying to them, I'm not ready to be a dad. I do not want you to go ahead with this pregnancy. So there was an expectation that what his wishes were about this unplanned pregnancy were going to be prioritized. What she wanted didn't matter. There was sort of a lot of threats and attempts to control, blackmail around finances, and even threats of physical violence, but it was very specific to this decision about the pregnancy. These perpetrators weren't trying to control the women, other aspects of their lives, or it wasn't a sort of context of coercive control. And often what happened was the woman would have the abortion, and then the perpetrator would leave. So even though she'd done exactly what he demanded of her, he still left. So that was, really a case of, clearly they're not trying to control her life. They've just removed themselves from it. What they wanted is to continue on with their life in the way that they decided, and just take no responsibility. So that was that group. So that was, in almost all cases, pregnancy preventing RCA. The next group along spoke about their partners wanting children as part of this illusion that they'd created for themselves of being a perfect dad. So often these men saw having children as a sort of social currency, if you like. They would push and push and push. We need to have kids. I really want to be a dad. You've got to get pregnant, all of this stuff. And then when the child was a baby and was cute and portable, they would cart out this baby and accept all of the admiring comments, particularly from other women saying, oh, you're such a great dad, and saying to the woman, aren't you lucky? He's so hands-on and blah, blah, blah. And the reality was that behind the scenes at home, these men were not lifting a finger to do any of the actual work of parenting. And anybody who's got kids knows it's an enormous amount of work. They were not doing the night feeds or the nappies or the bottles or any of that. And when the children got a little bit older and sort of stopped being cute and cuddly and the attention dropped off, they wanted nothing more to do with them. So it was this very performative fatherhood. And women there were just basically a vessel to provide them with children. Then in the next one along, this was starting to get into a lot more of the context of coercive control. Women that I spoke to who fell into this category felt like the perpetrators were deliberately trying to get them pregnant, knowing that once she had a child with him, she would be tied to him forever and wouldn't be able to get away from him, basically. And then the children could be used as leverage to get her to do things. So often these perpetrators would, be forcing her to have sex or something like that, and threatening to hurt the kids if she didn't do it. So this was really kind of starting to get very sinister, and these women were talking about situations where they were very unsafe. So sort of perpetrator wanting to create a weapon of control, which was the children. And then the final category, these were women who had experienced reproductive coercion in both directions, so both pregnancy preventing and pregnancy promoting by the same perpetrator in the same relationship, which seems so counterintuitive. Why is he forcing her to get pregnant and then forcing her to have an abortion? This was such an extreme manifestation of control that it was like saying, you are so much under my control that I can make you be pregnant and then I can make you not be pregnant. So by using the woman's body, it was such a powerful way to kind of show his domination, that he even had control over what was happening in her body, her reproductive organs, all of those things. This is what the women told me anyway, how they perceived it. So this real feeling that they just didn't have ownership over their own body. Okay, so I'm just briefly going to touch on some of the prevalence data, and there isn't a lot of it. We're really only in the early kind of stages of understanding how widespread this problem is, and partly that's the sort of measurement issues that I flagged at the beginning, that some of the data we've got is sort of, we can't really rely on it because it's measuring not just RCA, but bits and pieces of sexual violence, of intimate partner violence. Comparatively, there's been a lot less work done in this space than on intimate partner violence or sexual violence. And most of the research, certainly the research coming out of the United States, only measures pregnancy promoting. So they don't ask about forced abortions. And so a lot of that is missing a large proportion of reproductive coercion. So there's problems with overinflating and underreporting at the same time, which makes it very tricky. So last year, I was lucky enough to be able to work with Professor Deb Loxton and her team at the University of Newcastle using data from the Australian Longitudinal Study for Women's Health, which is just an amazing national data set. They've got over 56,000 women or something who've been filling out these surveys about health and wellbeing for a number of years. And it's incredible. And so a couple of years ago, we put in questions about RCA into the survey, which was fantastic. And we finally got the data back from the first wave of women who had filled out the survey with those questions in. So these were women who were aged between 43 and 48 at the time of filling in the survey. So sort of towards the middle to later end of the reproductive years. And of those, 4.5% reported one or more types of reproductive coercion. So to give a bit of a comparison, in that age group, that is similar to the prevalence of diabetes and cardiac disease, some types of cancer. But if we think about how much attention reproductive coercion gets comparative to some of those health issues, it's just not even in the ballpark. But this is quite a large number of women who are impacted by this. And so within that, it was about half-half as to pregnancy preventing or pregnancy promoting, which again illustrates my point that by only measuring one type, you're missing half the people. So yeah, I feel like this now gives us a really good baseline national prevalence for RCA. It is, with the caveat that it is only reproductive coercion perpetrated by partners, and so it's not capturing those people who've had a family member or somebody else perpetrate. And this is at any point in their lives, so lifetime reproductive coercion. But still, I think it does illustrate that this is a pretty significant problem that really needs a lot more kind of funding and attention and development of best practice responses and all the things. We found also in that study that there were strong associations with experiences of physical violence, of sexual violence and harassment. And what they call harassment in this violence scale that we used is actually controlling behaviours, really. So it was things like stalking and turning up at the workplace and stuff like that. So I think harassment doesn't quite describe the actual behaviours that were happening, but that's what was meant by that. And so they were much more likely to also report reproductive coercion. Also, women who had a history of child abuse often were more likely to report reproductive coercion as well. So in terms of thinking about red flags of people who might present to a service, that people who disclose other violence or a history of childhood violence, I think it would be worth considering also asking them about reproductive coercion, because they may not volunteer that, of course, but if they've had one of these things, then chances are that you could be also picking up a proportion of people who have got RCA and who need support around that. In terms of the socio-demographic associations, we found that because this was a longitudinal data set, we could look at things that they've reported in their 20s and then whether they were more likely in their 40s to report RCA. And so we found that women who were partnered really young, so between 18 and 23, they were more likely. The way it's written there is a bit confusing, but basically the ones who were partnered young were more likely to report reproductive coercion later on. Women who were in financial stress in their 20s were more likely to report reproductive coercion later on. And then smokers as well, which I think is the same for IPV, that there has been an association reported there with IPV. Quite often in the literature we see this. But so I think that also is interesting, that intervening early and engaging early with younger women who are in sort of these long-term relationships young, particularly if there's a big age gap between the partner, that can sometimes be problematic as well. That's from qualitative research that I've done with survivors, that there's this sort of power dynamic there that can be conducive to coercion and reproductive coercion and sexual violence and all those sorts of things. But younger women who are also experiencing financial hardship, that there's maybe opportunities there to intervene earlier with those women to avoid them then going on to experience reproductive coercion later. In health settings, there's quite limited data still, but there's been a couple of studies done in different health settings. So one that I was involved with a couple of years ago, where we looked at counselling client data from Murray Stopes and Children by Choice, and we looked at the number of people who were reporting reproductive coercion, so based off the clinical notes, and it was around 15%, so quite high. We do normally see higher prevalence in health settings than in the community because of the health impacts of violence, and people are going to health settings more. In general practice, quite a lot of years ago, I did a study where I was looking at sexual violence and had a couple of questions about only pregnancy promoting RCA. And even just looking at that, it was around 10%. So 10% of women who were accessing Victorian general practice clinics reported some type of pregnancy promoting RCA. I think we asked about whether they'd had somebody non-consensually remove a condom and somebody had forced them to be pregnant. Interestingly, in the New South Wales family planning setting, they only found 2.3% prevalence in a study that they did recently. And I don't really know why that is, because the way they ask the questions is quite good. But yeah, it was unusually low compared to some other settings. And one that I forgot to put on the slide there, but has in the intervening time also been reported, was Sexual Health Quarters in WA. They're also doing great work in this space around screening and response to reproductive coercion in sexual health settings. And a study that they did, I think their prevalence was around 6-7% in that setting. So that's just another example of a different clinical setting. So it's definitely something that would be cropping up fairly often in health settings, and particularly ones where pregnant people are going. So it's really important to sort of be front of mind as a potential issue that people might be not talking about, but having, and that there's opportunities there to, provide support and help them with whatever it is that they might need. We know that reproductive coercion and abuse has a lot of negative health impacts for victim survivors. So unwanted pregnancies being the really obvious one, and also terminations, rapid repeated pregnancies, so like really short inter-pregnancy intervals, gynecological issues, STIs, poor mental health. All of these things have been found in different studies to be linked to reproductive coercion, even low birth weight babies and perinatal mental health. And also, we don't have good data on this, but certainly qualitative data from studies that I've done where it's really caused a lot of impacts on women's parenting, and then with potentially flow-on effects for kids who are sort of exposed to, I guess, the repercussions and aftermath of reproductive coercion perpetrated against their parent. So, for example, in this study, women talked a lot about feeling resentment towards their child because they didn't want to have that child. It was not their choice. And then feeling really guilty about having those feelings because, of course, as parents, when we become mothers particularly, the pressure and the expectations from society is that, you're supposed to love your kids. You're not supposed to express complex feelings about it. You are just supposed to smile and be joyful. And this can be really hard for women who've been forced into that. And, a lot of them were doing the best by their kids. And it's not that they were being neglectful or anything like that, but it was a struggle for them to mother. And then they just felt a lot of self-blame around those feelings. For some other women, though, they actually saw it a different way, where they saw the child as the only joyful thing to come out of a horrible abusive relationship. And the only problem with that was that they then tended to be helicopter parenting and be incredibly anxious about something happening to that child. And so that was difficult for them as well to sort of manage those high levels of anxiety that they were having. And in both cases, women felt very strongly they never wanted their kids to find out about the reproductive coercion, that their child had come from sort of a situation of abuse and being forced. So yeah, they felt like that was a secret that they needed to keep, and they didn't necessarily feel good about having to do that. So then I'm finally coming to some of the more practical things. So we do have a lack of good evidence to guide best practice responses. Research that I've done with health practitioners in the past, a lot of them talked about relying on their gut feeling to sort of work out something's not quite right here. And for those really experienced clinicians, that was fine. They were able to do that. But then people who are coming up who are more junior, who don't have the same level of on-the-job experience, they don't necessarily develop those skills straight away. It takes time, it takes experience. And so how do we kind of upskill more junior staff to be acquiring those skills more quickly? And this is sort of an issue. I mean, whether we encourage sort of shadowing or some other mechanism where people are able to fast track those skills. For some practitioners, reproductive coercion is just not on the radar. So some work that we did in the primary care setting, a lot of those doctors and primary care nurses just didn't think about that. They just didn't consider it. They were already having to ask a lot of other things during the clinical encounter, and reproductive coercion just sort of wasn't something that jumped to the front of mind as a question to ask their patients about. Even if they were thinking about it, then they didn't know how to ask about it and were worried about saying the wrong thing or just not asking the right questions. We don't have good data about risk factors that you could go, okay, if somebody presents with this, this, and this, then we know that we need to ask. That data is still emerging and it's not robust enough that we can kind of make really strong recommendations. Women do feel that current domestic violence screening tools, so I know there's routine screening in a lot of health settings for domestic violence, but women don't generally feel like those questions capture reproductive coercion. So they might say, yes, I don't feel safe at home, or I've been hit or hurt or controlled or whatever, however the questions are being asked, but none of those questions necessarily capture these kind of sometimes quite subtle and nuanced pressures and coercion that could be happening around reproduction. And so that's an issue where even if domestic violence is being disclosed, the reproductive coercion gets missed. And then in terms of interventions, I've been working on a review of global interventions, and there's something like 4 interventions that have ever been developed for reproductive coercion. Some people may be familiar with Arches, which is probably the best known one, and that's an intervention that was developed in the United States in the family planning setting. And it's basically a counselling intervention with some provision of safety information and contraceptive information to anybody that discloses. But it really hasn't been shown in trials to be super effective. It does a few little things. I think it increased uptake of harm reduction strategies. So sometimes the harm reduction strategies were things like safety planning or using forms of contraception that are less detectable. It did increase that a little bit, but that improvement wasn't sustained over the longer term. So it's been really difficult to work out what sorts of interventions might be effective in health settings, because obviously ultimately this is perpetrator behaviour, and any intervention that you do with victim survivors can only do so much at stopping a behaviour that is the perpetrator doing it. But I haven't heard of any interventions for reproductive coercion with perpetrators anywhere. So that's obviously another gap that really needs to be filled. So some additional red flags. I mentioned already the ones that came out of the longitudinal women's health study work around the financial stress and relationship, early and young relationships. But Some other things that women have mentioned to me in qualitative interviews as what they saw as the things making them more vulnerable to reproductive coercion, they talk about this contraceptive vulnerability. And by that, I mean that for whatever reason, they were not able to use woman-led methods that they were in control of. So often they had issues that meant they couldn't take hormonal methods that made them sick or had other impacts on them that were really negative for them, and they didn't want to take that. They didn't want an IUD or other things like that. And so they were kind of left with the option of condoms or withdrawal. And of course, those methods at the best of times have issues. Certainly withdrawal is not particularly effective. But then if you have a perpetrator who's actively looking to undermine these methods, obviously it's way easier for them to do that with, whoops, I forgot to withdraw and things like that. So these women often felt like they didn't have mechanisms to control their own contraception and to use the contraception to prevent pregnancy. They just didn't, that just wasn't really an option for them in the current setup that they had. So that's really an issue, I think, if they're not able to access methods that are less detectable and that they're in charge of, that can really make them vulnerable to perpetrators. They talked about having a lack of sexual autonomy in the relationship, with not really able to say no to sex without sort of pretty severe repercussions, or even just sort of exhausting repercussions like being constantly harassed and pestered and you don't love me, oh, you must be cheating on me, you know, all of this kind of emotional blackmail. That the mental burden of that was really, really exhausting. And so for a number of reasons, they didn't have a lot of control over their sexual autonomy in that way. Large age gap in the relationship, as I mentioned, this is something that a lot of the women talked about, was feeling like they got into this relationship with someone who was older and more experienced, who was telling them this is how things are, and just not having a lot of general autonomy in the relationship because of that dynamic. Other IPV, of course, and controlling behaviour generally in the relationship, you know, being told what to wear, who to see, all of those things. Community or religious norms around reproductive decision making could also be problematic, because perpetrators could then weaponize those as a way of controlling the woman's choices, so threatening to reveal that she'd had an abortion, for example, where abortion was very much taboo in their community, and using that as sort of leverage to make her not have it. A lot of them mentioned feeling really ambivalent about pregnancy, and this is something that's come up in a number of the research projects that I've done, where women find that going to particularly sort of obstetric care and things like that, and health practitioners that are working with them around pregnancy, that there's this assumption that they're going to be happy about the pregnancy. And they weren't often. They were feeling really ambivalent and just they hadn't had a lot of choice about it, and not sure what to do, and that no one picked up on those feelings. That practitioners saw what they wanted to see, which was, she's pregnant, this is great, congratulations, and not sort of interrogating or seeing some of the more subtle signs of, actually, this is not great news for her. And also experiencing heightened distress around abortion. And I mean, for some people, having an abortion is an emotional experience anyway, but particularly I think when there's reproductive coercion, and they're not wanting to have that abortion, and they're feeling like they may or may not have had personal views about whether an abortion is something that's right for them, but then when they're forced into that choice, that made it even harder. And so lots of them were presenting really, really distressed, and practitioners were not sort of interrogating that the reason for that might be that they were forced to be there, and just sort of assuming that, oh, well, you know, it's hard for everybody, so let's just kind of get on with it. And of course, this is not all settings. These are probably the worst examples of encounters that women had. So then, in terms of what we should be recommending and what we can, I guess, think about as good practice, even with the limited data that we have in the space. I would be imagining that asking, as I mentioned, about reproductive coercion, if other violence is disclosed, including history of child abuse and then vice versa, particularly sexual violence in the relationship, and those harassing, controlling behaviours, because those were the most associated with RCA in the national survey work. Sensitive inquiry around a general sense of autonomy around those reproductive decisions may encourage disclosure. We are working on developing screening tools for health settings, so that work is in progress. And we're thinking a lot about, how to ask these questions. And of course, in research, I'm always saying we have to be specific about intent and this and that to make sure we're capturing it. But in clinical practice, actually, the aim is a bit different. And I think there's a lot more space to ask broader questions that invite conversation and invite disclosure. And then because you can unpack with them later about what is actually going on, which you can't do if you have a survey with 3 or 4 questions in it. So I think those questions around how women are feeling about the pregnancy, how they're feeling about the abortion, what would happen if you made a different choice today, interrogating what they might be worried about, whether that is my partner's going to be mad or my family member's going to be mad or whatever it is, that those types of questions might be good ways to open up those conversations. Again, this is basically what I just said. I skipped ahead and got to the slide before I switched over, but there's lots of different ways to ask, and we don't really know which way is best yet. This is something we need to be testing and evaluating to work out which ways of asking are going to lead to the most people actually disclosing this. So again, just some other examples. Were any other people involved in making this decision? Can you tell me more about that? For example, your partner or your family or whoever it is that they talk about. So just those gentle and sensitive questions I think are good to be asking. More generally, what women want from healthcare providers. So my PhD student, Molly Wellington, who's just submitted her PhD the other day, hooray, she did a study with survivors and healthcare providers as well about responses to reproductive coercion, particularly in primary care settings. And what women said they wanted from healthcare providers was for somebody to give them permission, which is a tricky word, but what they meant was for someone to tell them it's okay to make a different choice, because they're hearing from the perpetrator that they only have one choice, which is what the perpetrator wants. And there's all of these barriers that are being put in their way, all of these things being held over their heads. You won't be financially supported. Everybody's going to think you're a bad person for having an abortion, this or that and the other, any number of things that were being threatened. But for somebody else to just come in and say, actually, all of those things can be resolved. There are supports out there. You actually don't have to make that choice. You can choose for what feels right for you, and I can help you do that if you want to. That was just incredibly empowering to them, to just somebody to give them permission to not do what the perpetrator was trying to force them to do. And of course, there are sometimes safety considerations around doing that as well. And it's something that people have to make their own clinical judgment about. But that was something that women said they wanted. They really wanted to be treated with kindness and empathy. Women experiencing reproductive coercion tend to have really high levels of guilt, as I mentioned, and that can be either way, whether they're having the child or they're having an abortion. For lots of them, they felt like they were, killing the baby, all of these sort of ideas that were being put into their head by the perpetrator. And to be honest, that is still there in society. There are still people out there who think that and who tell women that. But also having guilt around bringing a child into an abusive situation, having a child that they didn't want to have. There's guilt no matter which way you look at it. And so that guilt made them very heightened to any kind of negative or even neutral response from healthcare providers. They felt like even neutral was bad because they were projecting their own feelings of self-blame onto that and thinking, oh, they think I'm terrible. And so I think it's important that clinicians are going the other way and being really caring and empathetic and not being neutral, because the neutral can be perceived as bad as well, or judgmental. They wanted healthcare providers to pick up on those subtle cues and the red flags, not to assume that a pregnancy meant good news, because oftentimes for them it didn't. And so they felt like by saying congratulations right off the bat, that just shut down any kind of opportunity to talk about, actually, I don't really want to be having this baby. So I think being really attuned to those red flags and to people who are presenting with distress or ambivalence, and it may not be, but it's worth asking the question and just getting a sense of how they're feeling, and then maybe it will open up a disclosure. Maybe it won't, and that's okay too. And they really wanted to be helped to overcome those feelings of guilt and self-blame. So sometimes work around self-compassion can be really helpful if that's an issue for the patient. There's actually quite a lot of resources out there around self-compassion and exercises that people can do around improving self-compassion and trying to be kinder to themselves, because sometimes these decisions are tough either way. No matter what the outcome, each option is difficult and has its own challenges. And I think these women certainly spoke about taking on a lot of that guilt, and that it would have been good to have been helped to just lift some of that burden and understand that this is something that's been forced on them. It's not something they did. They didn't ask for it. It isn't their fault. So, you know, they're not groundbreaking things, but I think the context of reproductive coercion is important to understand and to tailor the response to that. So then most people are probably familiar with the LIVES framework that is the WHO's recommended first line response to intimate partner and sexual violence, but we can adapt those same principles to reproductive coercion as well. And again, this is something that Molly's talked about in her thesis and in her work. But, you know, obviously listening, having the consultation alone, all of those really basic things, and the empathy, inquiring specifically about pregnancy, abortion and contraceptive needs. And so thinking about whether there are particular types of contraception that can be recommended that are less detectable. I mean, even IUDs, perpetrators have been known to pull them out. So sometimes you can make the strings shorter so that it's not so obvious. Validating through reiterating that it's not her fault and that it's not okay, and giving it a name, because so many people aren't aware of reproductive coercion. They don't even know that it's a thing. So many women have said to me, I didn't know there was a name for this. I just thought that it was something that had happened to me, but I didn't realize that other people also have had this experience. And I think validating as well that it's okay to have complex feelings, and that she has the right to choose about what happens with her body. All of those things are important to validate. Enhancing safety, of course, the usual risk assessment things, but certainly thinking about if she's disclosed reproductive coercion in both directions, that might be a real concern of what else is happening in this relationship, because they could be really, really unsafe from physical violence or harm, and to check that. Again, the contraceptive safety, and if there's ways that she can take contraception more safely that the perpetrator is not going to find out about or interfere with. And then the supports. There are a variety of services that somebody experiencing reproductive coercion might need. It could be connecting them with specialist domestic violence or sexual assault services, depending on what they need. specialist services don't always really understand reproductive coercion. Sometimes they say, oh, we can't take them because it's not a safety risk or not enough of a safety risk, but being able to advocate for patients in that context, I think, is good. They might need parenting support, financial support, or other sort of practical things. And they might need mental health care if they're really struggling with some of these emotions and anxiety and depression and other co-occurring things that might be happening for them. And then finally, I'm almost done. I do want to leave some space for questions. The care model is a companion model to lives, and lives is more about what you should do. Care is about how you should do it. And so this is really around how to sort of do woman-centered or patient-centered care. And in the context of reproductive coercion, based on the research, so the C is choice and control, but specifically in the context of RCA, it's choice and control over those reproductive decisions. The A is action and advocacy. And again, in this context, it's around problem solving or helping the patient problem solve those barriers to reproductive autonomy, whether it's the financial issues, visa issues, which often also get weaponized in this context, abortion access, those sorts of things. The R is recognition and understanding. So understanding and recognizing the dynamics of reproductive coercion. So sometimes women talked about, for example, turning up to a service and being told they had been, why didn't they use contraception, or why didn't they use it more effectively? Those sorts of things, that those comments really show that the clinician is not getting what's going on here. And the emotional connection, which is huge in responding to RCA, that they've got somebody in their corner providing the empathetic support that's non-judgmental. And that was my last slide. That seems about right for time. I'm really happy to take questions, comments. Thank you.
I have so many questions. That was so amazing. I guess you talked a bit about the data being lacking. I wanted to look at demographics a little bit. I wanted to talk about intersectionality with women with disability and culturally and linguistically diverse women, and particularly families reinforcing the perpetrator's reproductive coercion. Any of those topics would be great.
Yeah, so I'm actually on a project right now, which is a linkage project funded by the ARC that is specifically on migrant refugee women's experiences of reproductive coercion. It's led by Nicola Sheeran at La Trobe Uni, and there's a whole bunch of amazing people on this grant, and we are hoping to really start generating some of that data around that. I mean, there's been a few pockets of work and bits and pieces kind of under other things. So there's a project that's being run out of University of Western Sydney that's more broadly around fertility for culturally and linguistically diverse women and migrant refugee women, and that's covered some aspects of reproductive coercion, but it's not the sole focus. I did a little bit of work a few years ago talking to service providers about when they see clients or patients that have experienced reproductive coercion and are from culturally and linguistically diverse backgrounds, and they said a lot of stuff around community norms and visas being weaponized, like if you don't have an abortion or you don't get pregnant, I'm going to cancel your visa, and those type of things. And that often women were in a tricky position with all of these sort of, I don't want to say vulnerabilities because it's not their vulnerabilities, it's like the structural things that facilitate it, but being not having good support networks here, not being eligible for a lot of services because of being migrants, language barriers, and situations where the perpetrator is the interpreter, and so they go to the health service and they're not able to actually advocate for themselves because the perpetrator is doing all the talking. All of those things that just make it a lot harder. But I think if we're able to in this project develop some good strategies for supporting women from those communities, that would be great. Disabilities as well. There's been a few little research projects on this, and that all of that seems to just suggest that for women with disabilities, they're at quite high risk, and that there's all these other contexts that can happen for them around sterilisation and things like that that are supposedly in best interest, but then can become really coercive. I think we really need to know more about those experiences, and I think we just need to do more work in that space to understand how best to support them too.
Thank you, Laura. We also have one from Sess in the chat here, which is, how soon do you think clinical guidelines are away?
Oh,
the big question.
Yeah, look, we're doing, from the work that I'm doing, I would hope by the end of the year that we would be putting something out. How widely those will be adopted, I'm not sure. Obviously, it'd be great if it could be taken up. But we're looking to develop, a screening tool and some guidelines for practitioners around to sort of support that screening of like, okay, what do you do after that and all of that stuff. I'm also working on an online intervention for women that could be used like when they've made an appointment, for example, for antenatal care or for an abortion, and they're waiting to actually have the appointment, that they could use this website that'll be like a sort of decision aid type of thing to help them work through what do they actually want to do and what might be the barriers, and that then they could bring that to the clinician with a sense already of what specifically they need help with, and helping to have it clear in their own head about their decision that's kind of free from interference. So we're still working on what exactly that will look like, but again, that's going to be sometime this year. So yeah, hopefully 2026 is the year.
We have all of our fingers crossed. Are those clinical guidelines specifically with GPs in mind, or hospital, or all healthcare providers?
I think it will be more general. I mean, there might be some tailoring needed for different settings, but I would not want to be just making them for one setting alone, because I think there's so many entry points into the healthcare system, and we've got to do no wrong door, right? So yeah, I would like for them to be more applicable.
Yeah.
How can the women's health sector support your work? How can we be involved in future studies? Yeah.
Just by saying that, basically, I'm really happy to work with partners, and yeah, if there's interest there, I'm more than happy. So we can just have a conversation offline, or work out what that might look like. I'm really open to it.
Great. Laura, thank you so much. This was very, very informative. I took lots of notes. I think my key takeaway from this was, a good response is service providers letting women know that it's okay to make a different choice. I really like that, and I like that it came, directly from women as well. So again, thank you for your time.